Hey, all, welcome to this episode of A Good Problem to Have. I'm your host, Tyler Olson, and I'm really excited about today's conversation. I get to have a conversation about private practice with Dr. Noah Kaufman. Noah, thank you so much for joining today.
Tyler, thank you for having me. Big fan of your work. This is great.
I appreciate that. And there's several things that I'm looking forward to talking about with you. We're gonna have a two-part series, so this is the first part. Um, the first part, we're going to be talking about the steps that you've taken into private practice because you started KaufCare, and that's is it accurate to describe KaufCare as an independent standalone emergency medicine service provider? Is that correct?
I mean, yeah, globally that would be right. I guess an easier way to say it is a DAC, a direct acute care. I think people have heard of and are familiar with direct primary care.
Uh-huh.
And so this is, and actually there are direct specialty cares, like direct surgical cares, like Smith Surgical Center in Denver here and Surgical Center of Oklahoma, kind of like the pioneers. Those guys are the OG legends. Dr.
Yeah.
Smith, and actually Smith Center here in Denver is named after Dr. Smith. And so it's a big hat tip. And all the DPC pioneers, direct primary cares, the docs that are going independent again because they really want to provide good, honest, transparent care to their patients and step outside of the really, you know, war-torn system, which is it's kind of a bad system at this point for a lot of people. Um, Maybe very good as a safety net. And so we are in there right in the middle of DPC and DSC. So, direct primary care and direct surgical or direct specialty care. And we're a new entrant. We're direct acute care. And, I guess we're different than an urgent care because urgent cares do very, very, very simple things. Strep test, maybe a very small minor laceration, but then they send most things to the ER. If you've got a blood clot that you're worried about and you need an ultrasound, you go to the ER. If you have certain bad fractures, your arm is facing the wrong way, you might go to the ER. A dislocated shoulder, you might go to the ER. A huge abscess or pilonidal cyst or something like that, you might go to the ER, or you'll be referred to the ER from urgent care. And urgent cares are frequently staffed by mid-level providers, some of whom are very, very good, but it's a variable level of training. And so KaufCare fills that gap between the urgent care and the emergency department, offloading up to 95% of what can be done in the emergency department with a board certified, qualified, emergency room physician, with transparent pricing and direct care with the consumer, with the patient. And so patients are really resonating with this. And yeah, DAC, direct acute care. And that's kind of how we are defining this new kind of category.
That's very interesting. We've been in association with two DPCs over the past several years.
Hmm.
Um, One in the Midwest when we were living there, now out east here in the New England area, and we love that role. And like we are,
Oh, yeah.
I can't remember who it said. It was there's someone that we mutually know on Twitter X. He said something like, we should not be we should not be insuring against like the low expensive primary care, something like that. And I appreciate that, the role of the insurance premiums we pay relative to like the free uh preventative care visit. Like, it's not, the value add is awful. But whereas the
Hmm.
DP role, like, we pay a monthly subscription, and it is like we have a relationship, they know us, we have access, and
Hmm.
they're charging enough that they're not over. Well, I can tell they're chill enough. Like, not chill, like obviously nothing is ever that easy, but the balance of like mental stress is they're striking it, and I can see you're trying to build that with in your niche of acute care, which is awesome.
Yeah, I mean, and we do a ton of procedures, so that's a lot different than direct primary care. So the direct primary cares will send, if they're like I said, if they're worried about a blood clot or an effusion in the knee, I can put an ultrasound on someone's knee, see an effusion, drain it, send it off to the lab, et cetera. We do labs at our spot. We have X-ray, ultrasound capabilities, so we can take off 95% of what goes to the ER, and then help our DPC colleagues. And by the way, we're referring to DPC because my wheelhouse is not managing chronic diabetes or cancer or heart disease, or even like really simple problems. I can deal with those, but it's not generally cost effective in a more procedurally heavy place like the ER or a DAC,
Mhm.
like a direct acute care like KaufCare is. And so and we need the ER, and we still have relationships with hospitals because I've had to send people to the ER for serious problems. And so that's been very interesting too, to kind of negotiate those rapids and figure out those growing pains as we grow this, because it's really a new category, because a freestanding ER or an ER is subject to EMTALA laws and needs to see everyone. It is the perfect safety net for society. And as an ER doc of over 20 years, I can tell you, we get paid the same hourly, no matter who we see, no matter what we do. I could be saving a baby's life, intubating a baby. I could, who's having a seizure. I could be, dealing with a gunshot wound to the chest and putting in chest tubes. I could be dealing with snot-nosed kids for, like an hour or two straight. I mean, every door is a different, like, what are you going to get?
Yeah.
And you can have multiple crazy things coming in, and so a lot of those things need the hospital. But then we see a ton of abscesses, lacerations. Like if you got a big dog bite to your face and half your cheek is hanging off, um, the urgent care is not going to see you. And you would think you would need the ER, but you can come to KaufCare now. Like we're a new category. And as long as you're not having a heart attack or a stroke or life or limb threatening problem, or vision or like
Mhm.
a primary sense, then you can come to KaufCare and get really good care for transparent prices at a fraction of the ER. So instead of like a $12,000 mystery bill and a set of mystery bills over the next 6 to 8 months or whatever it is, and then collections, you're going to get good, honest, straightforward care. And all of our prices are published online, and we tell people our prices, before we do any treatment. So it's pretty cool.
That is very cool. I love that you're building this out. I have I have three primary questions that I'm hoping we can use as a guide for the rest of our conversation. Um,
Yeah.
the first is about business development. Actually, well, the first two questions are both about business development, but for the purpose of viability and liability mitigation. And then the third question is, who do you think in medicine should be considering this path? So, but first, like from a business development standpoint, what did you do to build it so that it is viable?
Yeah, fantastic starting question. Nobody's really asked me that. And so this is really interesting. Um, so to make something viable, by definition, you're making it so that it can survive and live, and generally that implies growth or at least stability. And so from a business standpoint, we need to pay for the lights, right? We need to pay for the lease. We need to pay for the staff. And so having a good understanding of costs from the beginning and what the burn rate would be and what the startup capital would be, and having a really strong plan and a financial team. And so I'm very lucky in that I have some advisors. I'm all self-funded, and I keep the cap table extremely clean. And I have no plans to sell to private equity or anything like that, but I do plan to partner with board certified docs. And so to keep it viable, we had to understand what the startup costs were, develop a pretty granular P&L,
Mm-hmm.
and then understand what cash needs would be, what burn rate would be, and these sorts of things that sound really basic to our business friends out there, and but you've got legal fees, you can make a spreadsheet for all this stuff. And being an ER doc, I'm good at like to-do lists. I'm good at juggling lists. I'm good at prioritizing and triaging because that's what I've been doing my whole life. And luckily, I've been a startup entrepreneur. Medicine kind of forces all of us to have side gigs and be interested in learning about finance and doing other things because over the last 20 years, I've been paid less and less and less, and everything gets more and more expensive all the time. And so, I've noticed this trend. And it's like I I started in my locums work and in my I finally stopped. I was a partner at UC Health for 8 years, and before that 8 years with another really strong group out in Lake Tahoe with some really great docs at both these groups. Still very friendly with most people there at both these places. um and but it was clear at the second after the second job, when I started to really learn deeply more about finance and get into some self sovereignty and and start considering fire. I just wanted to get out of the ER for a lot of my time. I love practicing medicine, but really, really stressful environment. You're working night shifts. It's a cortisol factory. And unfortunately, I became a patient, and I started to have a back issue myself, which then clued me into like how ridiculous the system is, because I'm all of a sudden the one making appointments with neurosurgeons and orthopedic spine and I'm like, wow, if I can barely navigate this, how can my patients? So bringing it back to become viable, I knew that I had to get out of the emergency room. And I didn't want to work for anyone else. I wanted to make my own thing and recreate medicine the way I thought it could be practiced optimally. And so, yeah, we had to sit down and think about viability. And like I said, it's all about making a P&L. I have a really great advisory team with
What's
former
it, what's
finance.
what's an advisory team? Like what is the expertise behind these people?
So the it's always important to have mentors and to understand your limits. Okay. So like I'm very good at certain things, but I leave like a startup founder's wave of destruction and disorganized mess in my wake. So it's really important to have people sanity check you and people who are just really good at what they do. And so it's like having different parts of a brain. And so startup advisors, so my main mentor, this incredible guy named Bill Giorgio, and he's just a superhero. And he knows everybody, and everybody loves him, and for good reasons. And he's been very successful in his life. And he was one of the chief marketing guys managing, a massive marketing budget for Stars Cable. And so I was very lucky, and he looked at investing in one of my early companies.
Mm-hmm.
And although I ended up going with private equity, and partnering with private equity, he still became a good friend, and we would spend time and talk. And even though he was more of a corporate guy, he was a very branding guy. He was a membership guy, and like very well understood a lot of things that I didn't about the way businesses work, and he managed huge teams. So he became a mentor 10 years ago, and it's really important to find a mentor. And he's the guy who said, Noah, slow down. You need a P&L. You need to know what the burn rate is. He's like, I couldn't have done anything I did without this other guy, Joe Zamora. And Joe is our finance guy,
Mm-hmm.
and he managed massive financials for a huge cable company, Stars. And so between these two guys, and they're an incredible part of our advisory team.
Mm-hmm.
And then we have a very strong marketing lead as well, who's now taking up social media and those things. So all of these super brains are like helping me, and then along with a ton of very basic stuff that the LLMs can offload. So Claude, Gemini, ChatGPT, I have round route, and they never get tired, and I can talk with them all day about how do I get my X-ray machine licensed with the state. Well, you need a state physicist, and you need to fill out this form, and you need to do this, and then like, oh, we want to see this Medicare patient, but they want to be cash pay. How can we do that? Well,
Mm-hmm.
you need to call, so I have like an endless list of advisors now that I have my agents and my AIs to fill in what I don't know on the basic side. But then
Mm-hmm.
for strategy and for the human elements and like how do we make this billboard, because we're about to like launch billboards and radio ads and all this stuff.
Mm-hmm.
Yeah, I mean it's really important to have a good team behind you. You if you want to do it alone, you're like an absolute psychopath. And some people can. I just don't think I would be able to do that.
Yeah, I mean, trying to wear all the hats, things are going to fall through the cracks. I don't think that there is
Yes.
anyone that can do it. They might think they can, and they might be able to for a short period of time, but they will ruin something in their life or in their career.
Have a
So
heart attack.
yeah, yeah. So what I hear from you is P&L, profit and loss. For those of you that don't know what that means, basically you're building out a business plan to be able to identify what's what are the steps to be able to get the infrastructure, so location, equipment, staff, software, and how to organize all of that. It costs money to purchase, it costs money to maintain, and it costs money to like provide, to pay staff and such. um, and so the P&L is basically what can we charge, what is our revenue, and what are the expenses, and how can we widen that gap so that the profits grow faster than than the expenses, so that you're in the profit, you're in the black more and more, right? Is that right?
Yeah, that's exactly right. And you don't want it to be existential. So you need to make sure you've got a backdrop, that a cushion that you can fall into in case it's not viable, in case the idea doesn't work and you don't have traction if you're a startup founder.
Mm-hmm.
And so, look, I mean, the bottom line is if you go to make a lemonade stand, you need cups, you need lemonade, you might need a chair, you might need a table and a sign. So where are you going to get the money? Well, you're going to borrow $10 from mom and dad to get that stuff, or you've saved up your piggy bank and you're going to put some of your piggy bank towards it. Now, if you put all your piggy bank towards it, then you're risking a lot, right? So you really need to make sure that you need to have an understanding of how many customers, lemonade drinkers you need a day to break even, and
Mm-hmm.
then what the viability. And so viability is basically, is the lemonade stand going to last for more than a week, and
Mm-hmm.
and is it going to be worth it? Because if you just break even, then yeah, okay, maybe you're providing medical care, you're doing good in the world, that's great, but you're never going to be able to grow and scale the concept. And basically, I think Albert Einstein said, yeah, just worry about becoming a value in the world. Think about creating value. And like that was his quote about, business. And I think like all of us want money and want freedom, but at the end of the day, when you get sucked into something like this, you realize that there's an opportunity to really change medicine fundamentally and help people in a big way. And once that kind of realization happens, you're like, okay, well, I want to create value. I want to scale this thing. And so now, we've been open for a month and the traction is insane. We're already profitable, which is insane. We're way past our existential risk. The traction is great and we're growing like, and I have vibe coded an incredible amount of AI agentic tools to follow every metric, and that shows us our viability. It's kind of like hooking a patient up to a monitor. You need a monitor if a patient is, uh, when a baby's born, we take the vital signs right away. And
Mm-hmm.
so I have continuous vital signs coming in from KaufCare, from my company, to let me know how we're doing. So I know patients per day average. I know, on different time scales. I know revenue per patient. I know, our burn rate. I know everything. And a lot of those vital signs for our company, which show us the viability, which you asked about, wouldn't have happened easily if I hadn't created these tools to track them in such a like easy to see summarized way. And AI really helps with that.
Mm. Yeah. Okay. Yeah, this is helpful because I think it needs to be tangible, and obviously, like, you have to, like, you need experts who know more than we do, and be humble enough to take advice and correction, and
Yeah, that's huge.
and make adjustments, and then yeah, and then actually building out the business plan. I So in an effort to not invade your privacy, but I did have a question. You mentioned self-funded, being self-funded. I think you did. And so
Yes.
to that point, do you think that someone needs to, like, someone that wants to pursue this, like, obviously, like, you can borrow funds, but, like,
Hmm.
someone's in medicine and, like, they're sitting on their own, like, employee job. We'll just say someone in EM, because, like, that's where you are, and they're thinking about doing this. Like, do you think it's realistic that someone in emergency medicine could create their own personal financial plan with the intention of, in 5 years and 7 years or something like that, build up the cash to self fund? Like, is that realistic, do you think, for most EM docs who are coming out of training now?
Well, it's not the startup capital or the money that is the hard part. I think that most EM docs and yeah, and I mean, if you live well below your means and you want to start something like this, it can be done. It can be done. But I would say that that's like somebody getting out and not doing a residency and trying to practice emergency medicine. I think it's very difficult. It's very hard. I mean, this is hard for me, and there's been sleepless nights. I don't want, to I mean, I want everybody to do something like this because I think medicine fundamentally needs to be fixed. However, I don't want to, kind of oversell this as like, oh yeah, I'm going out on my own. This is amazing. I'm profitable. I just saved up some money and did it. It was great. Like it's very, very hard. And there have been sleepless nights and existential dread. And even knowing what I'm doing and having multiple businesses in the past with some successful businesses under my belt, and private equity partners and investors and like a lot of experience with business, as an ER guy and finance, like have my Series 65 and all that stuff. Like I think there's there's a level of not expertise, but there's a level of experience that helps you weather the storms because there's so much unexpected stuff. And with the lease and negotiating the lease and location, and getting the, I mean, it's like creating a sculpture and you're an artist. And I'm not the best artist. And that's why I have these great advisors. And why I really have to be tactical. I have other strengths that are really good, and I'm at this point really good at medicine. I knock on wood, I've never been sued, and I've avoided the minefields, and like I love my patients, and I'm good at practicing medicine. But it's totally a totally different skill set to be a startup entrepreneur. So you can raise the cash. I think any EM doc can do this, and it's part of the reason why I envision a future where I'm working with all my ER colleagues to give them an alternative path and to give them a turnkey solution by either franchising KaufCares out, or consulting, or just helping other ER groups create KaufCares, or their own branded, direct acute care solutions and other and other docs have done this. There's other ER docs who have started down this path, but there's no national model. And so, our vision is to create a national footprint, and grow this brand into something that's very powerful for people.
I'm glad you mentioned that, because I know a lot of EM docs, and they well, I'm going to tell them about you. If
Yeah.
I haven't already. Just because, like, the stresses you mentioned, about the gradual degradation of compensation because of, insurance reimbursements and all that, it's getting to them, and it's causing a lot of changes in the financial decisions that they have to make. So anyway, this is interesting.
Yeah.
So then the other aspect of the business development, you mentioned not getting sued, so congratulations on that. What did you
Yeah.
do? What are you doing to keep that track record in the business development side of things?
Well, that sort of thing is, almost a philosophical question in medicine. And I think this falls into the it's better to be lucky than good. I've also been doing medical expert work for the last 15 years out of like the 23 that I've been practicing. And so I think I know and understand the mechanics of lawsuits and documentation traps and real risk that gets ER docs into trouble, and that gets docs into trouble. And I've opined on hundreds and hundreds of cases at this point, impartially, of course. And so like and I've served on peer review committees, and so like I think that I have insurance, obviously, malpractice insurance, and that's part of the equation that fits on the P&L on the spreadsheet as a
Right.
line item, and the thing is, my malpractice is pretty good, not only because I'm in Colorado, which is a decent state for medical malpractice, but um, also because I'm I'm not yet as busy as a full-time ER doc, uh, and so that's just something you need to start. You need to pay for everything when you get out and go on your own. The system does not make it easy. You have to absorb every cost and think of every little. You need to think of every little thing and cross all your T's and dot all your I's, because yeah, if you get sued, that could ruin everything, and that happens, whether it's a frivolous lawsuit or, look, we're practicing medicine, things happen, and so to mitigate risk, that's almost an entirely different philosophical discussion on how I practice medicine and why I haven't been sued, partially, and some of that is like being extremely extremely nice with patients, and some of it is talking to my patients about how medicine is probabilistic, and I don't have a crystal ball, and I don't know exactly what the best route is always. Here are
Mm,
the options. Here are the options, and I'm a guide. And what I can tell my patients is, look, this is prospectively reasonable, and this is what other reasonable physicians would do with a similar set of training and a similar experience. But I can't say this isn't going to get worse. Let's be careful here. Let's be smart. Let's rule out the real bad stuff. And
hmm
then, stay away. And then personally, I have to stay away from anchoring bias and confirmation bias when I'm practicing medicine. So I'm in a constant state of, I don't know what the hell's going on. And I think like that's a very honest thing for a doctor to say, but like it's true. And
yeah,
I think, it's patients are now all running to the LLMs and putting in their x-rays, or they're coming in and they're saying, hey, well, I, reviewed this whole thing that I have going on with ChatGPT, and what do you think, doc? And then the doc leaves the room and they put it into ChatGPT, you know, but there's a big difference because, the doc putting it in knows the right questions to ask and the inputs to put in, and is going to get much better outputs and
yeah.
is going to get much better direction. But either way, um, especially emergency medicine is a minefield. So it's a really good question, Tyler.
That's interesting. Managing expectations is not something that I thought you would say about. I mean, it makes perfect sense, but managing patient expectations. I do something that's not too dissimilar, because like we get a prospective client and they're like, well, what kind of investment performance can I expect? And I'm like, you can't expect anything.
Right. Right.
Because
Yeah.
like
Well, what do you
I'm
think the weather will be like next spring?
precisely, yeah. So
Yeah. Yeah.
you have to be, and kindness, that is so good.
Yeah.
I
Yeah.
kindness, because like we're all people, and like anyone who comes to you or to one of your colleagues, or in my field, me, they're coming for help and they feel vulnerable, and we're the expert, so we have to be very delicate with that responsibility. So yeah, because like insurance,
Yeah.
that's
We're all family.
yeah, the
What were we going
insurance.
to say about insurance?
Well, the insurance thing is like a no-brainer. It's like, well, yeah, of course you need a good malpractice insurance policy, so that
Hmm.
obviously you would have that. But then the extra layer of communication and like the relationship with your patients, like that is awesome.
Well, it's foundational, right, to
Yeah,
medicine and caring. And it's funny because we've kind of lost our way with that. And I can tell you firsthand, being, a burned out ER doc, just like everybody else, like morally injured, um, it is so hard to go shift to shift to shift to see the endless hordes of humanity with the constant problems and people's different expectations and go room to room. And people don't realize that I just left this room where this father of three kids just died from a stroke, at 45 years old, and I worked him for a half an hour, and then I walk into another room where mom and dad have been waiting, their kids playing on an iPad, and they're like horribly worried because their kid had 104 fever at home, and now their kid's fever is 99 because they gave Tylenol on the way in. And it's very easy to it's very, very hard to maintain kindness and understanding that of everybody's having an emergency in the emergency room,
right.
and so you can't say stuff like, well, I don't think you're having an emergency today, something simple like that, which you would think would be very reassuring. To some people that's like, well, I know that, like if it gets very challenging in medicine, especially, but once your patients are yours and
Yeah,
not like the hospitals, are not part of the system, and you're not an agent of a group or a hospital or whatever, but once it's yours and your name's on it, and and it's your interaction, and they're paying you directly, and and it changes everything. The relationship changes, and it's just much healthier and much better for the patient and for the physician. And it's just a very powerful thing. And then kindness becomes like very easy because I think we're all like pretty good people at the, ER docs are caring good people. You don't like spend that much of your life and money and come out with all this debt in your 30s and have all these financial issues, et cetera, et cetera, um if you don't fundamentally want to help people.
yeah,
So kindness and treating people like your family, I mean, that should be like, it should be a no-brainer, but the current system makes that very, very difficult.
mm, yeah, yeah. I can see that from the outside. Well, last question. It's I guess I'll call it a two-parter. Who should not follow you down this path? Like I do want to know who you think should. But in medicine, what sort of circumstances could someone find themselves in where it's like, this is probably not a good idea? Like, and maybe it's a specialty specific question. Maybe it's a, um, disposition question, financial disposition. What do you think?
Well, I don't think it's financial disposition because anybody can really do that, but I think that you need to be all in. You need to be fully committed. So the people who should not follow in my footsteps are the people who are trying to make money. If you're just trying to make money and you don't have a vision for creating like better healthcare, or it's gonna be like it's going to be really hard. Emergency medicine right now, you work 9 to 13 shifts a month or whatever,
Mm-hmm.
and you make and you make pretty good money, nothing compared to like what we used to make, and vis-a-vis purchasing power, but you make decent money, you can pay off your loans and afford like a decent life. um and that's a pretty comfortable position. Even if it's even if it's stressful, you get a lot of time off. If you like need that time off and the stress is a problem, you should not follow in these footsteps, because it is very stressful, and it's not easy. And and it's like I've been a rock climber for 36 years, and I've climbed everywhere, and I have free soloed in Yosemite, 1,500-foot cliffs, and like I've climbed very hard. So I would not recommend people to free solo unless you've been climbing for a long time. And this is a little bit of a free solo. It might not be fully existential because I'm keeping a certain amount of safety cushion, but it's fairly existential, and it's much different than working in the ER. So like if you have any doubts, you should not do this. We're trying to create an easier path for people to do this, but it's not fully created yet. um there's a lot to do, and it's just going to absorb all your time. I mean, look, right now I'm working 9 a.m. to 9 p.m. every single day except for Saturday, Sunday, and I want to work Saturday, Sunday also, but I like need the psychological time off to get up into the mountains and hike and stuff and spend with my family. But and I'm on a call, like I can leave and come back from the clinic if there's no patients, and I live close. But so it really needs to be like a very well thought out plan, to where, like for me, there is no stopping. Like I cannot stop. I cannot hire somebody. Just I could, but like it's expensive to hire another doc, or and part of what we're doing, I don't think we're going to be using mid-levels unless they're extremely experienced. So, and then the final thing is, I wouldn't the person who I wouldn't recommend to follow us is someone who hasn't been practicing for at least 10 years. Like your medicine better be like A plus, like you better be comfortable in every situation. Because I've had people come in to the clinic already who have rhabdo and their kidneys are failing and they have to go to the ER, or a vasculitis with a fever. And you really have to have that experience to know that this person is sick or not sick, because sometimes they don't look sick and their kidneys are failing, and they're joking around and laughing, and if you send them home, it's not like the ER where you can get every single test and you've got all the backup in the world. So you have to really understand medicine and really understand risk. And so I would only recommend, so I would say people who shouldn't follow me are like new EM docs, new grads. I think that, I mean, look, I'm not the best doc in the world. I don't think I'm probably decent. So like, there's certainly 10% of docs, or 20%, or 50%. I don't know, but who are better than me, smarter, maybe not nicer, because I'm really nice with my patients, but just more knowledge, just really good at emergency medicine. I mean, I've just met geniuses out there who are just so good. And so maybe those people could do it from a younger standpoint. I wouldn't have been able to do this until at least 10 years into my career. And I think that moving forward, as we work with other ER docs or groups to grow this model and expand, that's the type of physician we'll be looking for, is like, you got to be an A plus doc already.
Yeah, yeah, that makes a lot of sense because the buck stops with you, right? Yeah,
Yeah. Yeah. I mean, and there's risk. There's always risk when you're dealing with people's lives or cutting into them, and dealing with like their hardest moments.
sure. Yeah. So then, who should follow you? Who do you think this is? Who do you think should be paying attention particularly?
Well, I don't think anybody should follow me unless they really are a masochist, or even a sadist, like you have to want to endure some pain. I think this is best set up for groups to follow, groups who want to open their own thing on the side and want to do a direct acute care experiment and
Mm-hmm.
have the funds and go in together and can take turns working one day at the KaufCare or whatever they want. But like this is a smart idea for the remaining independent groups. And a lot of groups start to make their own freestanding ERs,
Mm-hmm.
but taking insurance, like you can't even take Medicare and Medicaid because they pay so little. And taking insurance, you need levels of bureaucracy and you need to employ a lot of people. It changes your P&L significantly,
Mm-hmm.
so that you need a lot more staff just to deal with the insurance. So look,
Yeah.
8% of the healthcare dollar goes to the healthcare team. 8%, 8 cents on every dollar. That's insane. That means there's 92 cents of value extraction. Okay, plus or minus a little bit, depending on the program and the system. But there's 92 cents of value being extracted from the patient and the healthcare team before the actual value part, you know, hits for the patient, which is their interaction with their healthcare team, the plan, the
Yep.
procedure, the surgery, the whatever it is. And so that is nuts. And when you go out on your own and you're doing a direct acute care, you remove all of that so that it's 100% you and the patient. And there is no value extraction. The
Mm-hmm.
value extraction is like necessary. It's like paying for the EHR, and you get to select the best EHR, or paying for the medical malpractice insurance, which we need. And I honestly don't think is bad. I think tort reform is a whole different question, but being a part of the medical malpractice world, I actually don't have as many problems with it, as a lot of people do. And it's not because I benefit from it. It's because I do think for a lot of us, it helps us to practice, uh, you know, prospectively reasonable care. But so the people who should follow me probably are ER groups and very experienced ER leaders and doctors who are not only good at medicine but have come to understand finance and what it takes to start a business, operationally. And I think it would be a lot less stressful for a group to come in, and that's probably why we'll franchise or co-own,
Mm-hmm.
and work with other PLLCs, and then help manage and help with a turnkey solution of, look, these are all the the millions of things we do. Here's your P&L. Here's everything. So like, here it is.
Yeah.
And with the agentic tools that we've built, to monitor the success and the vital signs of the business, I think this becomes, like you led with, a very viable, and important, valuable contributor to society that's filling the gap between urgent cares and ERs. So yeah, groups and very experienced ER docs. Anybody who's happy with their life, and is making enough money. You have to realize you're going to trade a lot of that peace and a lot of that, cooking dinner and spending time with family, and like, this is not easy.
Mm-hmm.
And so I think if a group can break up the financial responsibilities and risk and the actual staffing risks and like the time, if I was part of a group of 7 or 8 like-minded, um, ER docs, then I could come in with a bunch of capital and I could make something like this way easier than I'm doing.
Mm-hmm.
But there's a lot of risk. And then things go south, and there's a lot of cooks in the kitchen. So it's
Mm-hmm.
best if you have one leader. So like a CEO managing this, a CEO of a group. So those, I don't think that I wouldn't recommend this to very many people, but I think that the traction that I'm seeing and the potential profitability, both monetarily, but then also the psychic profitability and the emotional profitability of, taking like the best care possible of people, because
Yeah.
that is a form of revenue, right? That's a form of moral revenue and of like feel good revenue, because like it's just as important to feel good about what you're doing, as like you could be making all the money in the world, but if you're really not moving the needle on like helping people, um, then what are you even doing? I mean, yeah, it's like you're kind of like a Scrooge or somebody. So yeah, that's who should follow me is uh, follow my lead is other docs and groups who are interested in this. They're welcome to reach out, and we'll start efforts to start doing this within the next year anyway.
Very cool. Yeah. Well, this has been insightful. Yeah, I mean, for anyone who's looking to see what Noah's up to, go to kaufcare.com, KAUFCARE.com, just to see what you're all about. Your pricing page, well, as a flat fee planner with pricing on my own website, I really appreciate this because it's just nice to just be out there with it, and I'm sure that your
Yeah.
patients appreciate it too. Like, and then they know what they're walking into, and then the money part, it is important. It's a relevant way in order to convey value and to be able to receive services, all that. But you want to get it in a way where it's like understandable, and then you can like tuck it away, and then it's not the thing that's draining our energy, right? So
Well,
like,
I also own everything. So if a patient comes in, I can knock off $300 if I think that it's like a very minor abscess, and I'm like,
yeah,
you know, I'll do it for a couple chickens,
yeah,
like. I mean, I've had people say like, "Hey, can I pay in 2 weeks when I get my check?" And I'm like, "Yeah, sure." And it's a
yeah,
handshake, and I love that. It's like literally pay me in chickens. I've been paid in cash. We've got a bunch of cash in our drawer. I've been paid in Bitcoin. I mean, it's nuts. And then the like you said, the pricing page, I coded all that, and so I coded an ER comparison tool, and I had to do
mm-hmm,
a lot of research and cite a lot of sources on that page of where we got all our prices
mm-hmm,
from. But like now I know what it costs to do a simple abscess or a complex abscess or an X-ray, and our X-ray machine costs a lot of money, and so that's part of the P&L,
yeah,
and we got to keep the lights on. But coding all this stuff has been really, really fun. It's like intellectual sculpture using vibe coding, and so I'm glad you mentioned that. And I vibe coded an app also, so we have an app that has a pricing page also, and just on. Yeah, it's really cool. Thanks for mentioning that.
for sure. Yeah. Well, we got more to talk about. I'm curious to discuss your thoughts on some tax planning and Bitcoin and how that actually dovetails in with this practice that you're building, and I don't know, just to talk further on these topics. But for all of you listening, we're going to be breaking this into two parts, as I think I mentioned at the outset. So, come next week, listen again. Noah and I are going to be talking about tax planning and Bitcoin. Noah, thanks for this conversation, and I'm looking forward to the next.
Tyler, it was a really good one. Thank you.